There are certain drug classes that we know have more interactions. Acid suppressants interact with a lot of our oral anti-cancer agents, especially the PPIs. The SSRIs, SNRIs do have some interactions with tamoxifan's ability to function. So just some general classes that I'll look out for, as well as the cardiac comorbidities and underlying organ dysfunction.
I found that some patients might have a fear of reporting side effects. They're worried that they might, need a dose reduction and that they might not get the optimal doses of their cancer treatment, when in fact, by waiting until their symptoms have worsened and caused other complications, that approach is actually the opposite and the counterintuitive way to go. I always try to really emphasize it's better to take action, to take that antiemetic when your nausea is mild, to contact the office early instead of waiting for things to become severe.
Welcome to Medication Talk, an official podcast of TRC Healthcare, home of Pharmacist letter, prescriber insights, and the most trusted clinical resources. Proud to be celebrating 40 years of unbiased evidence and recommendations. On this episode, our expert panel discusses critical aspects of managing patients on oral cancer therapies. You'll listen in as our experts review tips for optimizing patient care and share best practices for handling these specialized medications. Our guests today are Dr. Jill Cassaday, a clinical pharmacy specialist at Banner MD Anderson Cancer Center in Arizona; Dr. Samuel Snowaert, a clinical pharmacist in oncology at Covenant Cancer Care Center in Michigan; and Dr. Lisa Thompson, a clinical pharmacy specialist in oncology at Kaiser Permanente, Colorado. You'll also hear practical advice from TRC Editorial Advisory Board member Dr. Craig Williams from the Oregon Health and Science University. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate challenges in practice, evidence-based practice recommendations, and other topics relevant to our subscribers.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. Please log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Now, let's join TRC editors, Drs. Stephen Small and Sarah Clockers, and start our discussion.
Let's hone in on how to keep our patients using these medications safe and start by reviewing interactions. So, Lisa, why are interactions common in patients with cancer?
That's a great question. I mean, the 30 to 40% that you have listed here from a study, I would say that it's probably at least that many patients, just because the longer patients are treated with cancer, the more therapies they go through, for instance. And then a lot of these newer oral agents, or even some of the older ones, undergo CYP metabolism via the liver or via other hepatic enzymes, and that also makes them very prone to drug-drug interactions. These might be an interaction with a medication that's used to treat an acute issue while the patient is receiving their chemotherapy, such as an infection. It could be an interaction with a medication the patient's taken for years for a chronic issue, for example, a seizure medication, or it could be medications that we're actually using to manage a side effect of the anti-cancer agent, such as drugs causing QT interval prolongation, for instance. Depending on the nature of the interaction, these could increase the risk of toxicity from the chemotherapy. It could reduce the efficacy of the chemotherapy, or it can impact the safety and efficacy of the other medications the patient is taking. These drugs can definitely cause their own share of drug-drug interactions as well. Supplements and other foods, such as grapefruit, can also impact the metabolism of these medications. And additionally, there are drug disease interactions that might need to be considered as well. For instance, some oral chemotherapy agents might worsen longstanding medical issues such as dyslipidemia, which would then require management.
Thank you. And can you comment, Sam, are there certain patients that you see in your practice that are at a high risk of experiencing interactions?
Sure. Several of the oral anti-cancer agents have cardiac side effects. So I think that's one of the biggest things we look out for is does the patient have any baseline cardiac comorbidities? Because that might require some increased monitoring. Also, when patients come in, we're checking obviously their renal function LFTs just like any pharmacist would in any setting. In our case, sometimes it gets a little bit muddy, I guess, because LFTs, if a patient has cancer that's metastasized to the liver, those LFT elevations could be due to the cancer rather than the patient having an underlying hepatic dysfunction. So we have to decide, is this the cancer or is this an underlying hepatic issue? And then if it is the cancer, do we start at a reduced dose or do we start at the standard dose and not sacrifice that, quote unquote, cancer killing ability of the chemo? So that's always the discussion. That's always a case by case basis. One more thing I'll add real quick too. Patients with cancer, they tend to have poor oral intakes. They tend to have low serum albumin. And for drugs that are highly protein bound, that can lead to increased side effects in patients who have let low albumin and poor oral intake. So I see the older patients listed as well. That can be sometimes something that we have to watch out for with them.
I'll also add briefly, Sarah, that because increasingly seeing these patients come onto our inpatient service on these medications that may or may not be there for the medications, but as we do medication reconciliation, if you're on enough medications, you're almost bound to have an interaction. So I'd highlight the last to the right there, polypharmacy. So as we're working on, if we have 2 pages of medications patients are taking, we're definitely on the look for there being interaction. But that's probably our biggest factor we see in the kind of general medicine setting. And it often then comes with more comorbidities on those patients who are on more medications, but number of medications is a big signal to us.
So I always am watching closely when patients have several drugs listed, several herbal supplements listed. I always do herbal supplement, review as well with patients. There are certain drug classes that we know have more interactions. Acid suppressants interact with a lot of our oral anti-cancer agents, especially the PPIs. The SSRIs, SNRIs do have some interactions with tamoxifan's ability to function. So just some general classes that I'll look out for, as well as the cardiac comorbidities and underlying organ dysfunction.
Excellent points. Lisa, what strategies do you use in your practice to screen for these and manage these drug interactions?
And I think the biggest thing is that thorough medication history that the other presenters have mentioned. It's one of the first steps is being able to identify and have that accurate list. Again, not only other prescription or over-the-counter medications, but also those complementary and alternative medicine products. And a lot of patients, especially those with advanced cancer, might be trying multiple strategies. And so it's important to make sure we keep those on the table as well. Additionally, you want to be aware of any medications they might be receiving that are injected. There are quite a few regimens that involve some oral medications as well as some injected anti-cancer medications. And so you want to make sure to have those as well. One other important thing to consider, these drugs, as have been mentioned, come with a very high financial toxicity for our patients. And while some patient assistance programs will permit filling at their typical pharmacy, others do not, and they involve the pharmaceutical manufacturer directly shipping drug to the patient. And so you want to make sure you have those medications included on your list as well. Medical information can also be really helpful in evaluating these. If it's a QT interaction, you'll need EKG results, potentially laboratory values. As the other presenters have mentioned, may also be required to adequately assess these and also to monitor. Sometimes we do say, okay, we need to proceed. And so we want to make sure there's a good monitoring plan in place. For a non-integrated system, that might involve the pharmacist contacting the prescriber's office, by phone, say, hey, here's the interaction. Do you have a plan to manage this? And in an integrated system, it can look like a multidisciplinary approach where, the entire care team is involved in monitoring for that interaction. So sometimes management strategies could be as simple as patient education, look out for this. Sometimes you need to change the dose of either the anti-cancer therapy or the other medication, and then also those monitoring recommendations.
Excellent. Thank you. Craig, do you have anything to add from your hospital practice?
I mean, let's add as kind of the generalist trying to keep up with all this, that you have to get familiar with and comfortable with your favorite drug interaction checker. So I'm fortunate to work in an academic medical center, and we have access to UpToDate and Micromedics, both of which have pretty good drug interaction systems where you plug in the 2 medications of interest and hit enter, and you get a pretty well detailed, accurate report for kind of what you should do. So we hope on the inpatient side, this has often been worked out on the outpatient side, but sometimes we're the ones starting new medications to be aware of. And there's too many of these to keep track of, I think, even if it's your practice area.
Something else that's useful too is if the patients are starting treatment inpatient and then coming outpatient, that having a good transition of care from the inpatient setting to the outpatient setting also helps us make sure that we're seeing the medications the patient's coming out on. So that certainly is beneficial as well.
Hmm. Wanted to transition now to the drug food interactions. So, Sam, I was wondering in your practice, what are some counseling tips that you've used for patients regarding some of these food interactions?
Sure. So the food interactions, like you mentioned, the grapefruit is probably the most common one. Something that comes up every now and then is pomegranate as well, star fruit, which we don't really get a lot of in Michigan, but and then Seville oranges, which are found in orange marmalades. Every now and then, patients are bummed that when we're taking away their orange marmalades, but those are interactions as well. And sometimes the oral agents do have certain recommendations as far as whether or not to take with food or without. If it leaves it up for the patient to decide with or without food, I tend to tell them take it with a snack. It seems to help settle the stomach. It seems to cause less nausea and diarrhea when they take it with a little bit of food. That's not 100% true, but it does seem to help for the most part. If it specifies how to take the medication, then I do tell the patient why it must be taken that way. So, like for example, capecitabine should be taken with food because if you take it on an empty stomach, it gets absorbed too rapidly and can lead to side effects. So, I will share that with the patient. Abiraterone's kind of the opposite, where if you take it with food, depending on what you eat, it could cause erratic absorption. So, patients should take them on an empty stomach. And I consider an empty stomach either 1 hour before or 2 hours after eating. I will touch on the supplements as well. This comes up a lot in the ambulatory clinic. Whenever I'm starting a supplement discussion with a patient, I always start those conversations in a very non-confrontational, open-minded manner because these are becoming more and more popular, especially on social media. So patients are asking about them more often. And patients who ask about them, they tend to do their own research. So I always start those conversations by saying, I think it's great that you're doing your own research and taking ownership of your health and taking your health into your own hands. Do you mind if I take some time to share what I know about these supplements? Or if I don't know anything about them, then I say, do you mind if I take some time to look into them before you start taking them? And then when I'm looking for interactions, my main concerns are, is this going to increase your risk of side effects from your treatment, or is this going to decrease the efficacy of your treatment? And if there are interactions, I share with the patient exactly what I find. If there's limited information, I share that with them as well. So if it's kind of a gray area, I'll kind of frame it as, listen, if you were my mom or if you were my brother or my grandma, this is what I would recommend for you to do, but I can't give you a solid yes or no. There's certainly some pharmacists that take the approach of just suggesting stopping all herbal supplements, and that's a reasonable approach because there is a lot of gray area in oncology, and we're kind of adding an unknown with this herbal supplement as well. However, lately it seems like there's a lot of distrust towards the medical community. So I think when we can find these opportunities to kind of find a common ground with patients and meet them where they're at, it kind of reminds them that you're on the same team as them. The sites that I like to use, Memorial Sloan Kettering Cancer Center has a great herbal supplement database, really good patient information and provider information as well. Also, Natural Medicines has a really good herbal supplement database and interaction checker as well. So I use both of those sites.
I really like the NIH's NCCIH Complementary Integrative Health website for information. There's actually a section there on cancer, and they're pretty blunt about these generally haven't been found to be very helpful. And that's a great site that for patients who are open to it, I have sent them there. And we always tell them we're not here to take away your supplements and herbals, but we'd love to educate you a bit more about these. And so we've used that NCCIH website quite a bit in helping with that in that area.
Great discussion, but I do want to move us along. We do have a few audience questions about side effects. So, Joe, can you comment? What are some common side effects you see?
Sure. So side effects are going to vary depending on the patient, the type of cancer, and also the particular oral medication that's being taken. Some of the common side effects that are kind of related to, a lot of these medications are going to be fatigue, nausea and vomiting, diarrhea, skin changes, especially of the hands and feet, mouth sores, and there could be some hair loss. Other frequent side effects include things like changes in taste, you have the constipation, a decreased appetite, low blood counts, and an increased risk of bleeding or infection. It is going to be patient specific. There are certain drugs, so we'll just use capecitabine tends to be the one that we're kind of talking about. So there are hand foot changes. It's something called hand foot syndrome. Basically, it affects the palms of the hands and the soles of the feet. Like it's red, can peel, they can actually turn darker, and the areas actually do become painful in some patients. And so, kind of, making patients aware of that. Some institutions will prescribe creams and lotions to help kind of ease that. When we have these side effects, what can happen is that it can delay treatment. It can cause dose reductions, non-adherence, those types of things. And eventually could, or overall could affect that survival. And so we want to make sure that patients are taking the medications at their optimal levels, if at all possible, and try to minimize those side effects.
Thanks, Jill. And when it comes to these side effects, Sam, how do you best prepare your patients?
So when I do my patient education in the clinic, I use education sheets to kind of help guide us both through the process. So it formerly was oralchemoedsheets.com. Now it's patienteducationsheets.com. You can search any oral chemotherapy and there's a very patient-friendly version on that website. So that's why I like to use. Patients like it. It kind of shows you, what the side effects are, what you can do to manage them at home, and when it's time to, call the clinic because it might be beyond managing at home. Whenever I'm starting a conversation with patients about these side effects, I start with, acknowledging, there are many potential side effects from these treatments. So I acknowledge that and I say, I'm going to review a lot of side effects with you today. Just because we're discussing them does not mean you're going to experience all of them. We just want you to know how you can manage them at home if they were to come up, and when to call us if it's not something that you should manage yourself. So, for example, when we're talking about capecitabine, I'm talking about LFT elevations. I'm talking about nausea, vomiting, diarrhea, the hand-foot syndrome, mucositis. There's a potential for cardiotoxicity with that one. There's the DPYD pharmacogenomics. There's a lot of stuff to go over there. But then at the end, I kind of summarize it and say, okay, here's your grocery list of things to go. Go get some loperamide. Go get a urea-based lotion. Urea-based lotion are typically any that are like for eczema. Urea helps with that hand-foot syndrome a lot. Have a salt soda rinse at home for mouth sores, and then pick up your antiemetics from the pharmacy. And I'll kind of summarize it up for the patient at the end. And I'll say, these are the things that we most commonly see in the clinic. Yes, it's possible there could be these severe side effects, but these are the things that we see most commonly, and this is how we manage them.
In addition to that, I always try to really emphasize it's better to take action, to take that antiemetic when your nausea is mild, to call the office or start that lotion when you're first starting to notice some redness on your palms and feet instead of waiting for things to become severe. I found that some patients might have a fear of reporting side effects. They're worried that they might need a dose reduction and that they might not get the optimal doses of their cancer treatment, when in fact, by waiting until their symptoms have worsened and caused other complications, such as, dehydration or acute kidney injury from uncontrolled nausea and vomiting, that approach is actually the opposite and the counterintuitive way to go. It's better to contact the office early to take that antiemetic early on instead of waiting for things to become severe.
I was just going to add, Sarah, that I love on the previous slide the kind of question-based approach for the patient and helping us meet the patient where they're at. The other thing we often encounter on the inpatient side, sometimes we're meeting patients when they're hospitalized for an adverse effect from the therapy. And one thing we're always working with both outpatient and inpatient oncology colleagues and the patient is, how are you doing on this therapy? Because they understandably, if their cancer is responding well to this therapy, they can be very committed to staying on that. And sometimes that can be difficult because of the adverse effects that they're having. But we always need to understand how their cancer is responding to the therapy to kind of decide how we're going to respond to the adverse effects that they're having as well.
Excellent. I do want to take a few minutes to answer some of these questions we're getting about how to manage nausea and vomiting. So, Jill, would you want to comment on that?
Nausea and vomiting, obviously, we will treat with antiemetics, again, depending on the risk of the emetic potential. And so NCCN has a very good chart that talks about the emetogenicity of these agents. It goes from high to low to minimal. And so each of those agents will be treated differently. So it's important for us to know where those medications fall and what medications we can give those patients to help with that nausea and vomiting.
Lisa, would you want to comment on that?
Yeah, I mean, I think the 5-HT3 inhibitors, granisetron and ondansetron, are probably the two most frequently take-home antiemetics that our patients receive. Even for oral chemotherapy agents that have a relatively low risk of emesis, we do typically give them at least one agent to take on an as-needed basis. For some of these regimens, a patient will be instructed, hey, this is a high risk. You need to take this 1 hour before every single dose, whether you think you need it or not. In other cases, it's something that we add as needed if the patient experiences it. There are so many different potential options to treat this. One important consideration whenever selecting one of these for an oral regimen is this isn't something that they're going to get only once every 3 weeks or every 2 weeks. This is something that they're taking their oral chemotherapy most likely pretty frequently. And so, what are the side effects of this drug when it's taken continuously? For instance, dexamethasone is an excellent antiemetic, but I wouldn't want to put someone on 8 or 12 milligrams of dexamethasone every single day, for 21 days out of every month. And so it's important to kind of consider that and have that as part of the consideration. And I really think that's why you see so much of the 5-HT3 antagonists used in addition to their efficacy, also some of the different side effect profiles compared to some of the others in this group.
The same thing with things like diarrhea. We already know that certain drugs cause diarrhea, so preemptively giving them an antidiarrheal to help with that certainly helps the patient in the long run. Things like mouth sores, the same thing. A lot of our breast cancer treatments do have the risk of, again, the hand-foot syndrome, the nausea and vomiting, the diarrhea, the mouth sores, those types of things. And so being able to just kind of upfront give the patients those medications to help with these side effects.
Thank you. We have a subscriber question about vomiting. So, what should we recommend if a patient vomits shortly after taking their med?
Sure. So a lot of that will be dependent on when the vomiting actually occurred. Kind of a rule of thumb, generally, if they vomit within about 15 to 30 minutes after they've taken their dose, it's possible that the medication was not absorbed or minimally absorbed. If it's greater than that, so 30 to 60 minutes or more, some absorption has likely occurred and retaking the dose could be dangerous. So ultimately, the patient really should be reaching out to the provider or making sure that they are aware when they get the medications that if they happen to vomit, this is what they need to do in that case. I don't know, Lisa, if you guys or Sam, if you guys do the same thing with that 15 to 30-minute window or the 30 to 60-minute window in your institutions.
My personal preference is if a patient does vomit a dose, I tend to tell them we're done for the day because if they vomited, this day and age in oncology, we really shouldn't be having patients vomit. Hopefully, we would be controlling that with antiemetics. So, I kind of use that as an opportunity to kind of refigure out their antiemetic regimen, get those under control. And I just get worried about there being potential for absorption. If they take another dose and vomit that dose up too, then we have 2 missed days. So that's my personal preference, but I don't think there's one right or wrong answer for this question.
Thank you for that. Sam, could you comment on serious side effects or symptoms that require immediate referral to the doctor or the ED?
Sure. One thing I touch on with a lot of these drugs, we mentioned them already, is a lot of these have cardiac side effects, sometimes even MIs or new onset AFib. So for sudden chest pain, chest tightness with severe shortness of breath, they should just go to the ER for that. Also, some of these meds can cause clots. So if they start getting the swelling, redness, pain in their lower extremities, they can call us, but we're probably going to recommend they go to the ER. Also, any fevers or any other signs of infection, like a new or worsening cough or even a UTI, patients should at minimum be evaluated at an urgent care, if not go to an ER. Things that can be handled more in the outpatient setting, obviously we've talked about the GI side effects, also changes in breathing, abnormal bleeding, bruising, dizziness, lightheadedness. Those are all things that I approach the physician about if patients are reporting that to me or anything that's outside of my comfort zone. And then, especially if patients are reporting any altered mental status or headaches, this may be a side effect from the drug, but also, unfortunately, cancer does metastasize to the brain, especially breast and lung. So, patients are reporting changes in mental status or headache. That's something that should be reported to the physician. They may need to do some brain imaging for something like that.
I still want to discuss a little bit about safe handling and disposal, and then just some other pharmacy considerations. So, Steve, I'm going to turn it over to you to discuss the handling considerations.
Thanks, Sarah. So, Lisa, what should we think about when handling oral anti cancer meds? We've actually had several viewers asking about this. What general tips should we keep in mind?
That's a great question, and it's one that I don't think always comes to the forefront of your mind as a dispensing pharmacist. There's an international group of pharmacists that have published recommendations about the safe handling of these products within the pharmacies. They include things like don't use your automated counting machine because of particulates that might aerosolize and then also contaminate the machine with every other medication in it. If you need to handle the actual medication, it's recommended to wear gloves and wash your hands after doing that. Don't crush or split or otherwise manipulate the tablets, even if that's a service that your pharmacy might provide for some patients. It's not something that you would want to do outside of a biological safety cabinet. And then also, when you are counting these out, make sure to use a designated counting tray that's cleaned after each use. One other thing to consider with these as well, a lot of these are meant to be dispensed in the original container, which can help mitigate some of these risks in terms of the staff handling it. But one other thing that I always like to note is that more and more of these agents are being supplied in dosing blister packs. So instead of the patient taking 2 tablets out of a pharmacy dispensed vial, they're popping 2 out of the blister pack. It's meant to improve patient convenience and adherence. However, I always recommend really closely examining the dispense quantity to make sure that you are giving the patient the correct quantity for their day supply, and then also ensuring your label is placed in a way that does not make it difficult for the patient to read the labeling and achieve their intended dose.
And in a similar vein, what are handling recommendations for patients and caregivers, Sam? In my experience, patients in the hospital see us gown head to toe in PPE and have questions. Am I supposed to do that at home when I'm handling these medications? What's your take on that?
Yeah, that's definitely a question that comes up frequently. And, the way I kind of frame that with patients is, these nurses or pharmacists are handling maybe these medications multiple times a day and different kinds of those medications. And we don't want them to be exposed to chemotherapy if they don't have to be, and especially when it's an occupational hazard. So that's kind of how I'll frame it for patients. When patients are at home, they can handle their medications, but they should wash their hands before and after they touch their medication, because if they get the residue on their fingers, they could be touching countertops, door handles, etc. If it's cytotoxic chemotherapy like capecitabine, it maybe be best to wear gloves, but it's just hard to tell a patient that they need to wear gloves for a drug that they're putting inside of their body. So as long as they wash their hands really good at before and after, I'm okay with them touching it. Caregivers, however, should wear gloves for the same reason that the nurses who are hanging the chemotherapy wear gloves and gowns, to protect themselves from the chemotherapy. We don't want people to be exposed to chemotherapy if they don't need to be. And that's kind of the take home point.
Great. And similar to that, what are some other household special instructions for caregivers? Thinking things like laundry or cleaning that may come up. Any recommendations there?
Sure. The big thing is any soiled linens or clothes should be washed on their own and washed twice. So if a patient urinated themselves or defecated themselves or any vomiting on their clothes or even drenching night sweats, I'd say it's like someone dumping a bucket of water on you. Those things should be washed in the wash machine on their own and washed twice. You can still share bathrooms with other people. You can still use public bathrooms. You can still hug, kiss, show affection to each other, but just take some of those extra precautions. Like if there are any drips or dribbles on the toilet seat, wipe those up. If they were to have diarrhea and the toilet has a lid, close that lid of the toilet, flush it twice to make sure everything's washed down. And then any accidents around the house can be cleaned with regular household cleaners. But if the caregiver is cleaning it up, they should wear gloves and they should just do a thorough job of cleaning it up. Treat it like there's chemotherapy in there, and then just do a thorough job of cleaning all that up.
Great. And then, Jill, how should oral oncology meds be stored? I'm sure it can vary by product, but any general tips there to share?
Sure. Some general storage guidelines, they need to be kept in the original container. This is to help protect them and ensure proper labeling. They should be kept in a cool, dry place, example like a dresser drawer or a kitchen cabinet, but not in the bathroom. And that's primarily because it can be hot and humid in a bathroom, which could affect the medication itself. If they're going to store it in the kitchen, it should be in a cabinet away from the stove or sink or even appliances. If it gets too hot, it can affect the medication itself. It needs to be in a safe location to prevent accidental ingestion, so keep up and away from children and pets. Some medications do have to be kept in the refrigerator. So, if that's the case, the recommendation is for the patient to put the medication in the container in a plastic bag or plastic container that they can seal and then put it in a place away from food and other things within the refrigerator. So, again, making sure that it's not close to the temperature monitor, those types of things where it's going to stay at a stable temperature within the refrigerator.
Great. And let's say we've stored it perfectly. How should we then dispose of them safely when we're done with the product? Any recommendations there?
Sure. The main thing is that they want to make sure that they're not flushing the meds down the toilet or dropping them in the sink. They should also not be put in the trash. I'll come back to this one in just a minute, but that's the general recommendation, is to not put them in the trash. Ultimately, they should be doing what they call the take back program. There's different areas. So there's a lot of pharmacies, especially like the pharmacy that they fill it at will have a bin, if you will, within the pharmacy that the patients can drop the medications into twice a year. Typically, like the police stations, fire stations, those types of things will have what they call a medication take back program. And people can bring unused, leftover, whatever medications to those places to have those medications safely disposed of. Kind of going back to the trash thing again, we recommend not putting them in the trash. But if for some reason the patient cannot get to like a pharmacy to return them or to one of those take back programs, the recommendation is to put those tablets in with kitty litter, dirt, those types of things, but again, in a container that's sealed and cannot be punctured, if you will. You can put it in the trash and then as close to trash day and put it out. But again, ultimately that's not the recommendation. That the take back programs are surely what they should be doing.
And some cancer centers have cancer drug repositories where patients can donate their unused, unopened medication. They have to be in their sealed manufacturer packaging, but it's nice if there's a patient down the road who has insurance issues or cost coverage issues, then that could be an option for the patient down the road.
That's a good call out there. And those programs generally have stipulations, for example, that meds can't be expired.
Yes, and keep in mind that you can search for year round drop off locations online. The DEA now says every day is take back day. So don't hesitate to refer your patients to your pharmacy team for help. And with that, let's talk about other pharmacy considerations for these risky meds. So, Sam, what are some strategies to prevent errors with these high risk meds?
Yeah, so I would say, from both the patient and the pharmacy perspective as well, I think what gets confusing is that these drugs aren't, they're not always just something, okay, take one tablet once a day. Sometimes there's a confusing schedule. They'll take it 2 weeks on, 1 week off, 3 weeks on, 1 week off. So there's some new drugs coming out where they just take 2 to 4 doses a week, and then that's not continuous. They still have a week off. So these schedules get quite confusing, like especially our multiple myeloma regimens can get quite confusing. So making calendars for patients helps a lot. Also, in the pharmacy, because we're trying to figure out these directions, the frequency, sometimes it's easy to miss, our easiest things, which are, renal and hepatic dose adjustments. So if you are at a pharmacy where you're verifying these medications, I would have a checklist. Check indication, directions, schedule, dose, renal hepatic dose adjustments, allergy, drug interactions, and go through that checklist each time. I work in the field and I still do this where I have a checklist because it's easy to just miss things when these schedules can get a little bit confusing.
I was just going to add, Sarah, in terms of taking medication safely, a touch point with a patient, if you have the time when they're not right in front of you, can be very instructive. So, seeing them on the inpatient side when they're discharged, they all get a follow up appointment when they leave our service. But if that gets missed, that appointment for some reason, they can suddenly be 2 or 3 weeks since they've been told how to maybe take a new medication or change a medication regimen. So, a quick phone call to them and say, "How are you doing? Tell me how you're taking that medication," can be important to see if they remember what you told them a week or two ago.
We hope you enjoyed and gained practical insights from listening to this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit. Just log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses. On those websites, you'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools. If you're not yet a Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insight subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% on a new or upgraded subscription with code MT1025 at checkout. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app, or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.